You know it's time for the Council on Aging show here on 102.1 FM WFOY, news, sports, and talk for St. Johns County. I'm Will Nassan with my co-host Brian Robinson. Good morning, Brian.
Good morning. Good to see you again.
Always good to see you. Always a good way to spend a Thursday. And we have a special guest here today. And Brian, why don't you
We do.
introduce?
We are privileged to have with us Charlene Beymer with Community Hospice. And it is someone that I have gotten to know in my role as program director for COA over the past 18 months. And she is just a delight to be around. And so
Yes,
I wanted
she
to
is.
bring her in and talk about community hospice. But before we get into that, I would love for our listeners to just learn a little bit more about you, who you are, how long you've been in St. Johns County. I don't know if you're a lifelong resident or moved here later in life, like myself 5 years ago. And so tell us about yourself and then how you got involved with community hospice.
Thank you, Brian. And I must say, it's easy to be a delight to work with when you're working with delightful people like everyone that's at Council on Aging.
I told like
She is delightful.
I just love having her around. She's already boosting my spirits.
I am being sincere. I do a lot of work with you all, and I see all the great things you do for the seniors in our community. As he indicated, I'm Charlene Beymer with Community Hospice. I've actually lived in St. Johns County since 1999, and I began working with Community Hospice. I sold a business, went back and got my master's in mental health counseling, and when I moved to St. Augustine, the first thing I did was volunteer with Community Hospice as a patient family volunteer, going into the homes. And when I saw the incredible difference that it made for the families and the caregivers, I was sold. I started work for them in 2000, and I have worked for Community Hospice in different capacities since then.
Wow.
Retired a few years ago, and then when they called and asked me if I'd come back, I said yes, because the mission is just so important to me. So, but I am working part-time, which is great.
That's good, and not always easy to do. You know, you get the call, and you gotta come back and heed the call. But good for you for going part-time.
Well, and I think that speaks to just how much you love what you do.
I do.
And what community hospice does for our community.
I know it makes a profound difference, and it's so important to people, and there are so many myths out there. It's important to be able to get out and share the information with individuals because there's still a fear of hospice. There are still so many myths.
Well, and when we think about it, you know, it's kind of like one of those things that you don't really think about until you're faced with having to think about it, right? So, for instance, like I think of all the different stores and businesses on the roads that we drive down, and we pass multiple of them, and then when there's something that I need, I'm thinking, well, what do I need? Where do I need to go? And then, you know, you kind of realize, oh, I pass that all the time, right? And it's kind of like
it's
this,
right
right?
there.
You don't really think about hospice until you're in that position that you need it. But for our listeners out there who might be like, I have no idea what hospice is, never even heard about it, would you, if you would, just take some time, and if we end up having our commercial break, we'll jump right back into it when we get back from commercial. But just kind of take your time and walk our listeners step by step through the process, if you would.
I'm happy to do so, and I like that analogy you just presented. Hospice is actually a philosophy of care. It's not a place, it's a philosophy of care that is dedicated to supporting people in their last season of life, in that last 6 to 12 months, to support them with dignity and to allow them to be comfortable. So the goal is when they're in our program, to provide, not only do we provide symptom management and physical relief, we also work with individuals on an emotional, spiritual, psychosocial level, and provide a great deal of support to the families and the caregivers.
Well, and what you said right there, hospice is not a place, it is a philosophy of care, and I think that's something that a lot of times gets lost in translation for a lot of us who use the term hospice care or hospice in our everyday, lives, and we think of it or talk of it like oh, it's a place, or they're going to hospice care, or hospice has come in and like, oh, okay, well, now this is what this means. But it's not just a place. It's not one thing. It's everything you guys do.
Yes, it really is. And we provide care for individuals wherever they call home, whether it be a private residence, an assisted living, a nursing home. We also have inpatient centers, and we have helped individuals living on boats. So it's really, wherever you call home.
That's pretty incredible.
It really is, because when you think of, this is the last moments of somebody's life. And I think, what better place to be able to spend those last moments than in your own home, whether that be a house that you've paid a mortgage on for years and raised a family in, or like you said, an assisted living facility, or even on a boat if that's what you call home. So I think it's amazing that you're able to do that and go in so that somebody can spend those final moments in a place that's familiar to them.
And that's important. It's familiar to them. They've got their favorite recliner, their family's coming in, the grandkids are in and out. So it's really important to have it, have that care for them where they're comfortable.
Mm-hmm. And so if somebody's out there right now and they're thinking, how do I even get this started? Like maybe they're in that situation right now and they're just not sure who to call, what to do. So what would you say to that person out there this morning?
Well, the care is for anyone with an advanced illness, and that's any sort of illness, whether it be, a lot of people think it's only cancer, but it's not. We work with individuals with advanced dementia, heart disease, COPD, kidney disease, end-stage HIV, ALS, just about any sort of end-stage illness. And when someone contacts us for care, and anyone can refer to us, most often we do hear from the individual's doctors, sometimes from the hospital, but anyone can make a referral. And then once that happens, we have an admissions team come out, assess the individual to see if they appear to be appropriate, because CMS does require that if they're on Medicare, a prognosis of 6 months or less, so it's someone that you might be surprised if they'd be here this time next year. And maybe what's happening is they're starting to fall a lot. They're sleeping more and more, bouncing in and out of the emergency room.
Indications that they're slowing down and things may be
declining.
trending there.
So that is one way that we can get it. And then once the nurse comes out there and they determine that they are appropriate for care, we do need a physician to certify that they believe their prognosis, no one has a crystal ball, but that their prognosis, given the disease and the state they're at, probably looking at 6 months or so. But the truth of that is, a lot of times people on hospice care, there have been some clinical studies that they actually live 29 days longer than they would without that support.
Well, and on that hopeful note, I'm going to interrupt you. We're going to take a quick commercial break, and when we come back, we'll have more about community hospice. This is the COA Show. All right, welcome back to the Council on Aging show here on 102.1 FM WFOY. I'm Will Masson, joined by Brian Robinson as always, and we are also joined by Charlene Beymer this morning from Community Hospice, and we've been talking a little bit about Community Hospice, how you got involved, and what you guys do. So let's pick that up.
What I wanted to share is after we do an admission visit, if an individual is appropriate, then we have a full care team assigned to them. And we have a nurse, a social worker, medical director. We also have some individuals like certified nursing assistants and volunteers. That's optional if people would like volunteers, like Council on Aging. Our volunteers are incredibly important to us.
Absolutely.
And they come into the home, they visit, they don't take over. We like caregivers to know that. We're not going to take over. The family and the caregivers are really the captains of that team. But we bring in the equipment necessary to make the individual as comfortable as possible, medications related to their admitting diagnosis, and our CNAs come and help with bathing and grooming if needed. The nurses are out there they help with pain and symptom management during visits, but I can tell you when my father was in community hospice with ALS, every time the nurse came in, and I was one of the primary caregivers, she did great things caring for my father, but every time before she left, she would look me in the eye and she would say, "What about you? How are you doing?" So it's really the staff gives a lot of guidance, I think, and that's really important.
Really important, and especially I always stump on the caregiver position, and I do it again here because it is so important, and so few people realize until you're in that situation exactly what you're looking at and dealing with, and it's hard. It's hard. It's sad. It's scary. It's lonely, and having people coming in who understand that and can take the time just to stop and say, "What about you?" is a tremendously valuable thing. Really, it is.
Yeah, it really does make a difference. And when I think back, my father had lung cancer. This was in 2003, 2004. And, I worked in the same place that he did. We both worked at the courthouse. He was elected the circuit clerk in Hancock County, West Virginia. And I worked in the magistrate court system. And, but we were both in the courthouse, area. And so everybody knew him, right? And so everybody was constantly, as he was going through his treatment, constantly asking me how he was doing.
Yeah.
And to be honest with you, I appreciated them asking that, but it got exhausting.
It's a lot.
Right. I was exhausted trying to tell them how he was doing. And it was very, very rare that somebody asked me how I was doing. And so that does make a difference when they take the time to ask the caregiver, how are you doing? That's just a great thing that is done.
Thank you, Brian, for sharing that. And I think we provide a lot of education for caregivers on ways that they can move their loved one without hurting themselves, on just different things to do, on reminding them that they need to get a mental health break. And that's a lot of times what our volunteers, if they would like a volunteer, they are highly trained volunteers. They are fully screened, criminal backgrounds, and they come in and they are just kind of a companion for the patient, and and also interact with the caregivers. They don't provide any hands-on care, but they listen. And sometimes patients in that situation have things they want to talk about that their family's not ready to talk about.
Sure.
And so
that makes sense.
The volunteers provide a good, confidential person that they can share with and look through old photo albums, read together, sing together, share memories, that sort of thing. And that's so helpful. And we also have, we assist with, how do you work with your grandchildren on accepting this? How do we make this part of the continuum of life for them so that they're not afraid, or your children? So a lot of people think of just the pain and symptom management, but it's so much more.
Absolutely.
And the earlier on you can get in the program versus the last few days, the more you get an opportunity for that guidance that can really make that such a different experience. And as our president and CEO, Susan Ponderstancil, says, when we change a death, we change many lives, and helping them to see things differently.
So again, talking about my dad, when he, got towards the end and we called hospice in, and I remember that night like it was yesterday. And we're coming up on 20 years ago now. And so it was a summer night in August of 2004. And I can still picture the hospice nurse who was there. Now, she probably doesn't look the same 20 years later, right? So I probably would not recognize her if we, Now, this was in West Virginia. So I live in the northern panhandle of West Virginia, squeezed between Pennsylvania and Ohio. So it's known as the Ohio Valley. And so it was Ohio Valley Hospice that came in. But she was phenomenal. And, she came in. First, she took all of us outside. It was August of 2004, so it's summer nights, takes us all out on our back porch and tells us what's going on, right? His breathing and the way his fingernails are looking, and just everything is pointing toward this is the last moments, right? And so then she took each one of us in, allowed each of us to go in separately so that we could, have a little bit of time with our dad, and my mom with her husband, and grandkids with their grandfather. And it just made for such a special time. And then what really blew me away was she came to the funeral home for visitation, and
wow.
I was not expecting that.
Yeah.
And so that was just phenomenal on her part. And I guess my question to you is that something that is typical of our hospice employees and nurses and so forth?
Well, I think a lot of times if there's any way that they can come, they will, because they bond with the families too. And a lot of times they say when they're walking into a patient's home, sometimes they feel like they should take their shoes off because they're entering a real sacred time and place. And it sounds as though you all really got great support.
We did.
And so it was wonderful that she could come. They're busy. It's not a requirement. But it's great that she was able to come. And I know a lot of times they do try to do that if they can, because they've become involved with the family.
Sure. And I would assume that they probably get emotionally involved with it. I mean, I'm sure they try not to. They probably try to be professional, but that's just human nature.
And we all know that. I mean, the work we do.
Exactly. And so I ran into her actually, a year or so later, and she had actually moved on, and she was in pediatric care and so forth. And so I guess another question is how long can somebody, or how long does somebody typically stay in this? And I assume it really has to be a calling for them to really do it long term.
It is a calling. It's definitely a calling. And we have nurses that have been with us 20, 30 years. We do have, you mentioned the pediatric. I know one of the nurses worked with us for years, and then when she had her own personal loss, she needed to break away. She worked in Flagler Hospital in the maternity area for a couple of years, and then she came back. So she went to the other end of the spectrum and then came back. But we do, just as we offer bereavement support, not only for the patients and families, but for anyone in our community, we also offer that to our staff because it's important for them to be able to work through this.
To decompress and unload some of it. Because, I mean, that's got to be, it must take an emotional toll. I can't imagine how it wouldn't.
Absolutely. Well, I was in ministry for a number of years. I was a pastor for 12 years and did numerous funerals when I was in that position. And yes, in order for me to do it well, when I spoke at the funeral, I put a lot of emotion into it. And so it can be very emotionally draining for the person that's going in there to care for them. So that's wonderful that you provide those services to your staff.
All right, and we are going to take another break here. We're going to get some Florida Network news, and when we come back on the other side, we will be back with the COA Show with Charlene Beymer from Community Hospice. All right, and welcome back to the Council on Aging Show here on 102.1 FM WFOY, news, sports, and talk for St. Johns County. I'm Will Masson, joined by my brilliant co-host, Brian Robinson, and we have our special guest today from Community Hospice, Charlene Beymer, and we are talking about all of the wonderful things that Community Hospice does, some of the processes involved in entering into work with Community Hospice, and some of the myths and misconceptions about hospice. So,
exactly. And so we'll get into myths here in just a moment, but I wanted to share one of the emails that we received from one of our listeners. Again, we have our own email for the show. It's radio@coasjc.org. So if you want to email us a question, anything that you've heard on the show or for an upcoming show, we'll be happy to address that. This is more of a statement than a question. This comes from our listener, Bob C. And apparently Bob C. actually knows you. We don't share last names on the air, but he says, I've told Charlene my story before, but I can't say it enough. My wife's last days we had with Hospice of Sarasota County. Came to the house and talked to the entire family. They made perfect sense of what they do and what their objectives were. I thank Hospice every day for what they did. It is too in-depth of what they did to share because of time constraints, and I just want to extend my heart to Charlene and the hospice organizations because they are God's big angels. So what a great statement, what a great testimony to how hospice helped him and helps families all across not only St. Johns County but throughout the country.
If you're out there listening, Bob, thank you. I always enjoy seeing you when I'm at Council on Aging, and never tire of hearing your story. Thank you.
Absolutely.
All right, so I wanted to get into this next part of the show here and talking about some of the myths that are out there about hospice, and I found this one very interesting. We recently had someone from our senior center who passed away, and this individual benefited from hospice care during her last days. And I was with one of the other seniors and talking to her about Jane, and that's not her real name. But she said this. She said, Jane will definitely qualify for hospice because she's Catholic. And so I found that interesting. And so I told this other senior, I said, well, hospice is not just for those who are Catholic. It's for anybody of any faith, and really you can be atheist and benefit from hospice. So any idea where that myth might have come from?
I'm not sure. There are close to 5,000 hospices in the United States, and she may have had some encounter with one that was supported through a Catholic organization, but hospice is really for anyone of any faith or no faith at all. They can be an atheist, and it's a service. It's paid for by Medicare, Medicaid, most insurance policies, but Community Hospice, I can speak for us, we are a true nonprofit, standalone nonprofit, don't report to stockholders, we report to stakeholders, which are members of our community, and we care for anyone, regardless of their denomination or lack thereof. And
you do have some chaplains available, which are optional. You don't have to have the chaplain come into your home, but if you'd like to, you could have a chaplain come in and be with the family and the person who is in their last moments.
Absolutely. And a lot of people do like spiritual support at end of life.
Sure.
And we have non-denominational chaplains. They are an optional team member. It's at the patient family request. And they come in and really meet the patient and the family at whatever place they're at. But it's great. I know when I was a recipient of care through my father, our church, we had someone from our church come in, our church family, but we also had the chaplain, and he would, come in and spend a lot of time with Dad, little time with the family, and sometimes we would sing, Christian songs together. So it was really helpful.
And I just want to say, I think that's a really nice, wonderful thing, because there is kind of a misconception a lot of times that if you're looking for this kind of help and care, that there is a religious component, and faith is hugely important to so many people, but also the ability to have these services and not have to profess a faith or demonstrate some kind of religious affiliation is huge, because we would be segmenting off a huge part of the population that just wouldn't be able to participate in this. So, a wonderful thing that's, to clarify that you don't have to be a particular faith. You can be who you are, and hospice is going to help you out.
That's great. So here's another myth that's out there. Hospice is only for people in their last days.
Oh, wow. That is the biggest myth that I work daily to try to bust that myth. We do get patients in their last days, but there's so much more we can do in that guidance and the acceptance, the experiences you had with working with the family. And it's really the earlier on, the more opportunities we get. We might do a life review with them. We have child life specialists that might come in and work with the grandchildren if necessary, if they're having trouble coping. And there's so much more that we can do. But oftentimes we do get people at that very last phase partly because they're afraid of hospice, but sometimes because things turn around really quickly.
Right.
And that does happen. And we're there for them when that occurs, to help them get through that portion and still get all the services to them that we possibly can. But earlier's better. And I also must say that, sometimes people think, well, if I get into hospice, there's no turning around. It is a patient-family choice. And if you sign up for hospice and the team starts coming out and you don't think it's for you, you just sign out. And sometimes with cancer, we get patients that have had chemotherapy, they're really worn out from the treatments and decide not to pursue them. And then once they're in hospice and their symptoms are managed, they're getting support, they might change their mind and say, I'm going to try that aggressive treatment my doctor suggested. I think I can do that now. They can check out, and we may see them again in the future, and we may not.
So in that instance, somebody that has cancer, and let's say that initially their diagnosis is they have maybe 6 months to live. So they could enter into hospice at that point in time?
Yes, and with hospice, one of the things is when someone's really kind of shifting from aggressive curative care to comfort care. So, and that's really a CMS guideline that, Medicare guideline, that sort of thing, because it's not set up to care for people for 5 years. Although we have patients that sometimes we get them when we say 6 months, we don't boot them out in 6 months. If they continue to decline, even if it's, that decline might slow up, we can keep them on our care.
Okay. And have you had anybody that's gone into hospice, like with that diagnosis, that they got 6 months to go, but then they get better and they have lived longer?
And we're going to pin that question with that answer. We're going to come back in just a few minutes. This is our final break of the hour, and we'll be back to talk more about community hospice. This is the Council on Aging Show. All right, and welcome back to the final segment of the Council on Aging Show, and we left you on a cliffhanger. We were asking a question, and Brian, I'm going to toss it right back to you.
Yeah, again, I was just curious if there's anybody that enters in the hospice and then ends up getting better and then kind of ends up living longer than what was expected.
Yes, and as I said before, if they're continuing to decline, although it's slower, we just recertify them and they can stay in the program. But we have people that get better and we graduate or discharge them. One example, we had an individual actually that I was doing a presentation at one of your Council on Aging locations, and they, a gentleman and his wife stood up and told their story. They came into the program, and at the time they came in, he was, had an advanced illness, was sleeping all the time, falling, all sorts of things. When we got him into the program, one of the things we do is kind of look at the symptoms you have, look at the medications, and we worked with him for a while and made some changes, looked at the person as a whole, and he wasn't sleeping all the time. He wasn't falling anymore. And we discharged him, and he is an active member of one of the, Council on Agings
That's incredible.
That takes the opportunity to do all the great things you provide as far as education and activity and socialization.
Yeah, really incredible.
That's great.
I mean, not something you expect to hear out of hospice because we think, okay, that's it, that's the end. But but it doesn't necessarily mean that.
Well, again, in my years in ministry, I minister to a lot of people, and some of them going into hospice, and that seems to be the norm. Once they get into hospice, then they kind of look at what medications they're on, how that's affecting the person, and adjust those medications. And a lot of times, what the symptoms that they have is because of the medication. So I think that's a great example of that.
And that's a little bit of a unique example. But a lot of times, people with cancer, COPD, but most of the people that come on the program do stay.
Right.
But I think sometimes, again, with cancer too, they feel better and they decide to do that aggressive treatment that they were not going to do before because they were worn out from the treatment they had. And without that treatment, they would have that prognosis.
Well, I want to make sure that we have enough time that our listeners know how to contact you. So if you would share your number and website, anything else that you have, so that they know how to get in touch with Community Hospice.
And Community Hospice and Palliative Care, we provide care in 16 counties. Our home base is in Jacksonville, and we our phone number is 904-407-6500 or 866-253-6681. And you can call that number for more information, or you can go to our website at communityhospice.com. And we have a very in-depth website, and there are sections for patients, for caregivers, a lot of good resources on there. Mm-hmm. So again, 904-407-6500, whether you're interested in the care or perhaps you're interested in getting some of the bereavement services we offer to community members that weren't under our care. But we have services where we help support them because that is part of what we give back to the community.
Mm. Okay, so you have bereavement support groups that folks can get involved with after their loved one has passed to help them through that grieving process. And are those various places throughout St. Johns County?
There are various places throughout St. Johns County. We do, for individuals involved in our program, we provide one-on-one counseling for anyone in the community that's had a loss. We do periodically, we do an understanding grief presentation. We do that at our Chapman Community Center across from Target on US 1.
Okay.
And on Tuesdays and Thursdays, we have a bereavement support group that comes in and these are individuals in the community that need that support, and they can come in for our support groups. Okay. We also have some in the northern end, so go on our website because there you will be able to find out where those locations are. We have them throughout our service area of 16 counties.
And that's at no cost to the individual?
That's at no cost to the individual, and it's our way of giving back to the community. We are well supported by our community. In fact, our Bailey Family Center for Caring, which is attached to the Flagler Hospital, the Mark Bailey and his father and his family helped to raise the funds to build that, and that was built totally through support from our community in St. Augustine.
That's incredible, and we are very, very fortunate to have the community we do, and especially people like the Baileys. They have been great custodians of our community.
They have.
It's amazing.
Generations now.
Yes, absolutely.
And this would be for anybody in the family. So it could be for the spouse, the children, grandchildren, anybody that wants to be involved with the bereavement.
Oh, yes. And sometimes it's, the best friend or and we have a camp for children a couple times a year because and it's from 7 to 17. Children grieve differently. So coming to that camp and having an opportunity to meet someone that's also lost their father and to be able to talk about that. And then there are a lot of activities that are really helpful. And those kids oftentimes come away from it with a phone buddy or something to be able to stay in touch and get that support and not feel so different than the other kids at school that, haven't lost their dad or mom or sister.
Well, we still have a few minutes left, so I wanted to kind of touch upon some of the other myths. And here's another one, that hospice is only for the wealthy.
Oh, no, it's paid, it's paid for by Medicare, Medicaid, and most insurances. But Community Hospice, we are a true nonprofit. We care for individuals regardless of ability to pay, and we provide $3-4 million a year worth of unfunded care. We have a pediatric program, which could be a different show, but that's one of the few in the nation, and that's totally self-funded. And at any time, we have about 200 kids in that program.
Wow.
Some at end of life, but some in a longer-term palliative process where we may care for them through adulthood, but they just need a lot of additional support.
So somebody out there who's listening right now who might fall in our low-income category, they can get the same type of hospice care as somebody who's very wealthy.
Absolutely. Absolutely. And that's just part of our mission, is to be able to provide that care and support our community, from our certified nursing assistant to our CEOs to our leaders. This is our community, and we're caring for our friends, our family, your friends, your family, and that's very important to us.
And this one kind of ties into it, this other myth that hospice will take possession of your home.
No, we do not take possession of anyone's home. We come into the home, but we visit, and we don't take over, nor do we take your home. That's, and I have heard that one before too. No, that is in no way the situation.
Yeah, that's a scary myth and a good one to put to bed. Nobody's taking your home.
Absolutely.
Another myth I think we can get in here real quick. You have to give up your current doctor.
Oh no, your doctor can be as involved in the care as you would like him to be. So that is not the situation. Some people have been seeing their doctor for 20 years. So no, you do not have to give up your physician. We work with them, special coding for the things you might see them for.
That's great. And then another myth: hospice is only for cancer patients. I think you've talked about that. It's for anybody as well. And then you also talked about this other myth: once you enter in the hospice, you can't get out of it. So you already shared a story about
patient family choice.
That you can get out of that. So those are just some of the different myths that are out there, which I'm sure you deal with quite often as you're talking about hospice. So we thank you for coming on the show today and just sharing about hospice and what you do and what's available for those who are at the last stages of their life and the people who love them. So thank you so much for being on the show with us today.
Thank you so much, and thank you, Will, and thank you, Brian, for all the great things you all do every day at Council on Aging for our senior community.
Well, and we appreciate your support of Council on Aging, the support that you give us and all of our businesses and different organizations in our community we just appreciate that and appreciate you. So thank you so much.
Thank you.
All right, Brian, Charlene, it's been a great show. And Brian, you and I will be back next Thursday at 8 a.m.
We will.
All right, we'll talk to you then.